So we'll see a demonstration of a case of L5S1 discectomy, left-sided disc herniation by UBE technique, that is unilateral biportal endoscopy. That precisely means that from one side we are making two ports for the endoscope, one the viewing portal, the other one the working portal, and thereby doing the discectomy. So here we will start the demonstration after clearing of the soft tissues over the lamina, and when we start with the bony work, let's go ahead. Thank you. So here we are doing laminotomy under this endoscopic vision with our 3 mm upcutters, doing the undercutting of the L5 lamina. Using our RF probe to clear off some soft tissues, the periosteum attached to it on the dorsal aspect of the lamina, and thereby using our burr to create our space for the 3 mm upcutters to work inside. Working on the ventral and the dorsal aspects of the lamina to remove the bone, and doing the laminotomy on our side, that is the left side, with this burr, that is 3 mm burr. Again trying with our upcutters to remove off some bone above the ligamentum flavum, and using the RF in probe in the coagulation mode to block any bleeding vessels at that site. Again using the upcutters to continue with our laminotomy on our own side, that is on the left side, working our way, doing the undercutting of the lamina. Because as we can see, the upcutters work more faster than the burrs as such, and there we can see that in the top corner, the V-shaped cut in the ligamentum flavum we can see, which is actually the joining part of the right and left parts of the ligamentum flavum in the midline. Using our burr to continue with the laminotomy and create more space. Using the burr to remove this overhanging part of the bone. Again coming back with our upcutters and trying to remove as much as lamina possible, and again switching back to the burr to create a space, basically to remove the attachments of the ligamentum flavum and hence thereby to remove it and to unroof our thecal sac in that area and the nerve root. Using the RF probe, as you can see in the coagulation mode, block any bleeding vessels. So bleeding is often a concern in endoscopy, which can block our vision, which can create a poor visuals for us, make our working difficult, can become a reason for complications endoscopic spine surgery. Thereby it's very crucial and important to handle and tackle all these bleeding small vessels in a very meticulous manner, which can make our working quite simpler and easier, and provide us a bloodless field, make things very clear and simple for us. as we can see, it was bleeding from this, so thereby we took our RF probe in the coagulation mode and trying to coagulate those bleeding vessels. Again, switching back to our upcutters, trying to remove part of the facet joints and doing the undercutting of the facet joints actually. Using the RF probe, trying to do soft tissue clearance over the lamina, which often also blocks endoscopic vision. Thereby, we are trying to clear it off and trying to clear our vision in front of the endoscope. Been using our burrs to do some bony clearance, that is part of the facet joint actually, and of course some part of the lamina, as we can see. Using a burr, do some laminotomy. So thereby, as we can see, we often need to switch between the burr and the upcutters and the RF to move ahead in this part of the surgery. Here we are actually doing facetectomy with our burrs. The overhanging part of the facet joint is being removed so that we can visualize the underlying ligamentum flavum more clearly and thereby remove it. So basically, simply we can say that the steps of surgery remain quite the same as we do in a micro discectomy or something like that, and like tubular discectomy, micro discectomy, or anything for that matter. Just that we are visualizing it through a different manner and in a different way. Instead of directly using our eyes, we are actually using endoscopic eyes here, seeing through the endoscope. And instead of an air media, we're doing it in a water media, which is actually providing us a clearer vision in form of that there is the field is not obscured by the blood, because obviously it is being washed off by the water that we are using, and also that it is well controlled in here because the water pressure is actually controlling the bleeding as well. Precisely, that is the spinal lamina junction where we are doing our burring right now. Right below there, if you try to see clearly, we can see that there's a midline where we see the split in the ligamentum flavum. Here with a dissector, we are trying to feel and trying to tease out the ligamentum flavum from the lamina. At the spinal lamina junction itself, we are trying to remove the bone with our kerisons. So I think I would like to say that if endoscopic discectomies are done with a little bit of expertise, it probably makes the life of the surgeon easier. It gives us better visualization, better control, and makes the surgery very precise and accurate. Makes it easier and reduces the chances of errors because things are quite clear in front of our eyes. The dural sac is being pushed a bit. It is a bloodless field. The chance of dural tears are very minimal, though all the complications which can happen in open surgery can happen in endoscopic surgery as well, but the chances reduce quite a lot. Also, the chances of infections also reduce grossly, as you know, we use lots and lots of saline over here. Continuing with the undercutting of the lamina with the kerisons and using burrs in between to further unroof the ligamentum flavum. All this is the bony removal, the laminotomy, the fascicectomy to clear the ligamentum flavum from its attachments on all the sides. The superior part of ligamentum is attached to the undersurface of the L5 or the upper lamina. The lateral aspect of the ligamentum flavum is attached to the facet, and the inferior aspect is attached to the S1 or the below lamina. It actually has two surfaces. The upper part is attached to the upper aspect of that is the dorsal aspect of the lower lamina, and the inferior aspect or the inner aspect of the ligamentum flavum is attached to the undersurface of the lower lamina. And the midline, we know, it actually attaches to the ligamentum flavum of the opposite side. So we have to detach ligamentum flavum from all the sides and remove it off to unroof our nerve root and the thecal sac on that side. And that's what we are trying to do. So again, this blood supply which is becoming a problem for us, trying to coagulate all that bleeding supplies, blood supplies. Because the epidural space is open here, the ligamentum flavum which attaches in the midline to the opposite side's ligamentum flavum, that V-shaped area is open. So thereby, once the epidural space is open, the saline loses its capacity a bit of stopping the bleeding vessels, because this once the epidural space is open, the saline starts flowing a bit up and down, and thereby that tamponade effect of that saline reduces a bit. So we often face these bleeding problems, which we can tackle easily with a bit of expertise. Trying to detach the ligamentum flavum from its attachments using a dissector. Using our RF probe to clear off the soft tissues that are coming in front of the endoscope. Using a burr again, do some bony clearance. Using keratins, doing undercutting of the facet joint. Trying to do the ligamentum flavum excision with our upcutters and removing it. Going on, removing it laterally. The dissector is trying to remove there's a thin film actually just over this nerve root and the neural sac, which is often not visible when we do open discectomies, but under this endoscopy we clearly visualize that, which we often remove off with our instruments, endoscopic instruments. Again, using a dissector, look into the attachments of the ligamentum flavum onto the lower aspect of the lamina, that is the lower lamina, and with an RF we can see that we are trying to remove the inferior attachment of the ligamentum flavum to the S1. Actually, if we have a hook probe, a hook RF, that really works very well for this. However, we don't have it with us, so I did the same with our regular RF. Removing the ligamentum flavum with the upcutters. Coagulating that bleeding blood vessel, which you can see. This is the ligamentum flurum, the inferior part, which needs to be removed, and thereby we are removing it with our rough cutter. That is undercutting of the facet joint. There we can see that the disc is shining just below the nerve root. It's actually pushing the nerve root posteriorly. It's kind of, it's playing the nerve root, pushing it from below. Trying to remove the attachment of the ligamentum flavum from the S1. With our hook probe, feeling around the nerve root. Doing the bony clearance around the nerve root, removing the ligamentum flavum, unroofing our nerve root. Here guys, like you can see that the disc is just visible. Yeah, here comes our disc, pushing the nerve root more medially with our RF itself, coagulating the blood vessels just over the disc. This happens when the water gets over. So always tell your assistant, one of the persons in the OT, to make sure that the water bottle soon, a new water bottle is always in the background, and you always switch from one bottle to the other, from one NS to the other NS, without your work being hindered in between. So this is what happens. The example of what happens once the saline is over and the next saline is not ready in place. Finally, our vision is clear again. There is the disc just below the nerve root. Such a beautiful disc we can see right there. So pulling the nerve root medially with the nerve root retractor and asking your assistant to hold it right there. And to the same working portal through which this particular instrument is inserted, to the same portal we'll insert our RF probe right there and doing an annulotomy there to the same portal. And it's basically same as a microdiscectomy, where the same incision we put our retractor, we put our other instrument. So same thing we are doing here. The working portal is anyways like 7 to 8 mm, so not a problem. The assistant is holding the nerve root with the retractor. Here we're using that Indian knife, which is a spear-shaped knife, and further doing an annulotomy and moving into the disc. This is the disc herniation right in front of our eyes, the whole cause of all the troubles in our case, and removing it right there with the disc forceps. Further going into the disc space to remove any loose fragments which might be there, which can become a reason for a reherniation. Doing annuloplasty with our RF to cause scarring. That is, theoretically it causes a lot of scarring around there and reduces the chances of reherniation. With our hook probe, again feeling around the nerve root for any sort of compression. Removing the ligamentum flavum right over the nerve root. Place it point right under the endoscope, burying it off a bit. Here it might appear as if we are doing a lot of bony work, but if you compare it with our other forms of discectomy, it's actually not much. Here it's very much magnified, so thereby it appears that we are doing a lot of bony work, but in reality it is not as much as we do in an open discectomy. People often ask me what to do if a dural tear occurs in this endoscopic discectomy. So if the dural tear is less than 3 to 4 mm, we usually do not need to do anything about it because we've not done anything much of an open work here. However, we should give a bit of a head-up position so that the saline does not move much into the dural space, and we can continue with our work carefully. But if it's more than 4 to 5 mm, then we should open it up and try to do the dural repair. moving around the nerve root, any possible sources of compression, and moving this ligamentum flavum right over the nerve root. Let's the vessels which are bleeding from there taken care of by the RF. Use it in a very low stage of coagulation. Whatever state we started off with, once we are near the dural sac, we have to reduce the coagulation to half power, and ablation mode should not be used when we are so near to the dural sac or the nerve root. The flavor needs to be removed, and that's what we are doing. So once again, I would like to stress upon the fact that basically all your steps of a microdiscectomy remain the same, just that you are viewing it in a different form. So one should be very clear with the basic steps of surgery with microdiscectomies once anyone ventures into this endoscopic discectomies. Just clearing off the foraminal part. With the nerve root moving into the disc space and trying to look for any loose fragments which might be there. Probing the foramen. Again retracting the nerve root medially and doing more of annuloplasty at that level with the RF probe. We're doing discectomy with the disc forceps and removing any loose fragments which might be there. So I'm not using any water pump here. It's not really recommended. Using gravity aided saline flow in our case. Pump can often result into many water related complications. It's better to avoid the pump. Here we can see some loose fragments coming off, which are very important to be removed to avoid the recurrences. We actually don't need much of very specialized instruments in UBE. The same discectomy forceps that is used for a microdiscectomy, the same RF which is used in arthroscopic cases. Some couple of instruments like the retractor for the endoscope, the retractor for the working portal, the nerve root retractor, the special one, the Indian knife. So some couple of instruments you need, but most of the instruments remain the same, which are often available in the good hospitals or in our own setup. This is such a beautiful picture actually. You can see the thecal sac, the nerve root. Both of them seem to be quite free now. We are just trying to be very sure enough that there is no ongoing compression, trying to clear the nerve root off from any residual compression from any of the sides. Trying to do as much as angioplasty as possible. Doing last steps of discectomy. Going around the nerve root with a dissector, looking for any residual components of disc, and to make sure that the nerve root is free from all the sides. That is the axilla part. With the nerve root hook, not the nerve root in the foramen. Just trying to be sure enough that there is no compression remaining behind. dealing with the nerve root hook medially, laterally around the nerve root in the foramen, just anterior to the nerve root, in the axillar portion of the nerve root that is medial to it, and trying to be sure that the nerve root is free. Is the end part of the discectomy. Once we close up the water, this is how it appears.